August 30th, 1945. A damaged hospital on the outskirts of Tokyo stands in heavy silence. Windows are shattered. Walls are scorched. The air inside is thick with antiseptic sweat, and the faint, metallic smell of blood. Ceiling fans turn slowly, barely cutting the heat of late summer. Rows of wounded men lie on thin cots. Soldiers, civilians, some barely conscious, others staring at nothing. Japanese nurses move quietly between beds. Their movements are precise, restrained. They pause beside certain patients, checking breathing, pulse, then stepping back. These men are not expected to survive. Supplies are scarce. Pain relief is limited. Death, in this room, is accepted as inevitable and honorable. Then American doctors enter. They do not pause. They do not accept the quiet judgment already made. They move directly to the beds marked for death. Bandages are removed. IVs are prepared. Orders are given calmly, firmly. Treatment begins. The nurses freeze. To them, this is unthinkable. These patients are beyond saving. To interfere is to deny fate, to prolong suffering, to violate everything they have been taught. Yet the Americans persist, working with urgency, refusing to step away, refusing to let these men die. In this room, surrounded by the wreckage of war, two medical philosophies collide. And nothing about life, death, or duty will ever look the same again. To understand the shock felt by Japanese nurses in the late summer of 1945, it is necessary to understand the world in which they had been trained to work. Japan's wartime medical system was shaped not only by material scarcity, but by ideology. Medicine, like every other institution of the empire, existed to serve the state. Survival was valued, but sacrifice was revered. By the early 1940s, Japan's medical infrastructure was already strained. As the war expanded across China, Southeast Asia, and the Pacific, military casualties mounted rapidly. Hospitals struggled with shortages of anesthetics, antibiotics, blood supplies, and even basic surgical tools. Penicillin was rare. Sulfa drugs were limited. Morphine was carefully rationed. Doctors and nurses were trained to work with almost nothing, forced to make constant decisions about who could be saved and who could not. Triage in Japanese military medicine followed a stark logic. Patients were classified not only by injury, but by usefulness to the war effort. Those likely to return to duty were prioritized. Those with severe wounds, abdominal trauma, massive burns, head injuries, were often designated as unsalvageable. In such cases, treatment focused on comfort, not recovery. Death was not resisted. It was accepted. In many contexts, it was even framed as honorable. This approach was deeply influenced by Bushido, the ethical code emphasizing loyalty, endurance, and acceptance of death. Soldiers were taught that to die for the emperor was the highest form of duty. This belief extended into medical practice. Prolonging life at all costs was not considered virtuous if survival meant weakness, disability, or burden. Nurses were trained to maintain composure, suppress emotion, and respect the inevitability of death when it came. Japanese nurses during the war were often young women, rigorously trained and ideologically conditioned. Their education emphasized obedience, emotional restraint, and efficiency. They were expected to endure horrific conditions without complaint, long hours, overcrowded wards, and constant exposure to suffering. Compassion was expressed through quiet presence, not intervention. To interfere with fate was seen not as mercy, but as disruption. By 1944 and early 1945, the situation worsened dramatically. Allied bombing campaigns devastated Japanese cities. Hospitals were damaged or destroyed. Makeshift wards were established in schools, temples, and factories. Electricity was unreliable. Clean water was scarce. Medical staff worked amid rubble and smoke, often treating patients during air raids. In these conditions, the philosophy of acceptance hardened. There was simply no capacity to fight death endlessly. As casualties mounted, so did emotional fatigue. Nurses learned to recognize the signs of impending death quickly. A shallow breath. A weak pulse. A certain stillness in the eyes. When these signs appeared, care shifted from intervention to observation. Hands were folded. Blankets adjusted. Silence was maintained. Death, when it arrived, was met without drama. This was the system in place when the war ended. On August 15, 1945, Emperor Hirohito announced Japan's surrender. Fighting stopped, but the wounded remained. Hospitals were filled with men who had survived bombings, burns, shrapnel, starvation, and disease. Many were beyond what Japanese medicine believed could be treated. Nurses continued their routines, expecting that death would quietly complete what war had begun. They did not yet know that a completely different medical philosophy was about to enter their wards, one that rejected inevitability, challenged cultural assumptions, and refused to accept that certain lives were simply meant to end. That confrontation would begin the moment American military doctors arrived, carrying not only supplies, but a radically different belief about the value of every patient. The arrival of American medical teams in Japan in late August and early September 1945 marked a profound shift in the environment of hospitals and clinics. U.S. Army Medical Corps units were trained under principles radically different from those guiding Japanese wartime medicine. Their doctrine emphasized that no patient was beyond saving, that every life was worth fighting for, and that medical care was a duty owed regardless of prior allegiance or perceived utility. This perspective was rooted not only in medical ethics, but in the broader ideology of the Geneva Conventions, which the United States had helped codify and promoted among its forces. American doctors brought both supplies and technology that were rare or entirely absent in Japanese hospitals. Sterile surgical instruments, blood transfusion equipment, morphine, sulfa drugs, and even early antibiotics like penicillin allowed doctors to attempt treatments that Japanese nurses had long considered impossible. Hospitals that had been rationing care and preparing patients to die now found staff equipped to intervene aggressively, to prolong life, and in many cases, to save it. The contrast was stark. What Japanese nurses saw as hopeless, American doctors saw as a challenge to be met with skill and persistence. This ideological and technological collision created immediate tension. Nurses, trained to accept death as part of duty, often found themselves watching procedures they had believed futile. Patients with severe burns, head trauma, or abdominal wounds, previously resigned to die, were subjected to blood transfusions, surgical interventions, and intensive care. The nurses' reactions ranged from awe to disbelief, sometimes bordering on fear. In their experience, interfering with fate was unnatural, even dishonorable. Now, their expectations of what was possible and morally acceptable were being systematically challenged. The cultural dimension of this encounter cannot be overstated. Japanese society had long revered endurance, resignation, and the ability to face death without complaint. The Bushido-influenced medical philosophy reinforced these values, framing life-prolonging intervention as unnecessary or even disrespectful. In contrast, American medical culture emphasized the sanctity of each individual life. Soldiers and civilians alike were to be treated aggressively, with the aim of survival, rehabilitation, and eventual reintegration into society. Nurses witnessed not just medical interventions, but a profound challenge to cultural norms and assumptions about life, death, and duty. Operationally, the U.S. Army was aware of the delicate cultural situation and instructed its doctors to proceed with professionalism and sensitivity. Officers emphasized that patient survival was paramount, but so was respect for the local staff. Cooperation, rather than confrontation, was encouraged. Even so, Japanese nurses experienced cognitive dissonance. Patients they had prepared for death began to recover under the Americans' hands. They watched procedures they had never performed or even witnessed. They heard doctors instructing, correcting, and improvising techniques to save lives. And in every case, the refusal to accept death clashed with deeply ingrained beliefs about honor, duty, and the natural order of life. By the end of September, hospitals across occupied Japan were transformed. Mortality rates among previously hopeless patients began to fall. Japanese nurses slowly adjusted, observing the results of aggressive intervention. Some began to assist American doctors willingly, adopting new practices. Others remained wary, uncertain if the defiance of fate was appropriate or ethical. Diaries from this period describe a mix of astonishment, fear, and gradual adaptation. The shock was not just technical, it was moral and psychological, reshaping perceptions of life, death, and responsibility. This context, material scarcity, cultural conditioning, and the arrival of an entirely different medical philosophy, set the stage for the multi-angle exploration of this phenomenon. Nurses' disbelief, patients' survival, and doctors' moral imperative intersected to create one of the most striking humanitarian confrontations in the closing chapter of World War II. The human dimension of this medical encounter was immediate and visceral. Japanese nurses, often young women in their early 20s, had spent years under a rigid system that demanded emotional restraint, obedience, and acceptance of death. They were accustomed to seeing patients succumb quietly, to adjusting blankets over bodies that would not survive. Yet in late 1945, they watched the unexpected, American doctors defying what nurses considered fate. The sight of a severely wounded soldier receiving blood transfusions, oxygen, and surgery, a patient they had assumed would die, evoked a mixture of awe, disbelief, and moral unease. Diaries from the period describe trembling hands, silent shock, and whispered questions among nurses. How can they refuse death? For patients, the impact was transformative. Men and women who had been resigned to die suddenly experienced intervention and care. Pain was addressed, wounds treated aggressively, and survival became a real possibility. Psychological relief, however tentative, accompanied physical treatment. Patients often reported confusion and suspicion, especially those from conservative or military backgrounds. Many had internalized the belief that enduring suffering or dying was honorable. Now, life itself was being imposed in a manner they could scarcely comprehend. The human response, shock, disbelief, and gradually, hope, illustrates the profound impact of American medical ethics on Japanese civilians and soldiers alike. From a clinical perspective, the American doctors introduced techniques and supplies that revolutionized outcomes in these hospitals. Blood transfusions, advanced wound care, and penicillin treatments became commonplace. Japanese nurses observed procedures that defied their prior training, surgeries on patients with massive trauma, aggressive infection control measures, and meticulous monitoring of vital signs in cases previously deemed hopeless. The American approach rejected triage decisions based purely on perceived futility. Every patient, regardless of severity, was treated as salvageable. This medical methodology was both scientific and systematic. Doctors worked in teams, prioritizing hygiene, intravenous support, and continuous monitoring. Nurses learned to assist in ways they had never practiced, measuring vital signs frequently, preparing complex medications, and supporting post-operative care. The learning curve was steep, but it became clear that aggressive intervention dramatically improved survival rates. Over time, Japanese staff began to recognize the empirical evidence behind these methods, gradually reconciling their disbelief with observable outcomes. Leadership played a crucial role in these encounters. American medical officers were trained to assert authority firmly but ethically. They insisted on following protocols that prioritized patient survival, even when Japanese nurses hesitated or protested. Orders were clear: no patient was to be denied treatment due to prior expectation of death. Officers emphasized the importance of discipline, coordination, and adherence to both medical and ethical standards. The leadership dynamic was also cultural. Japanese nurses were accustomed to hierarchical obedience, but in their system, authority often reinforced the acceptance of death. American doctors, by contrast, used authority to challenge assumptions, enforce life-saving interventions, and demonstrate that refusal to save a patient was unacceptable. This reorientation of command within the hospital setting created tension, but it also became a mechanism for rapid adaptation. Nurses who initially resisted gradually conformed, recognizing that leadership in this context meant preserving life, not surrendering to inevitability. The clash between American medical practices and Japanese cultural norms was perhaps the most profound source of shock. Japanese society, particularly under wartime ideology, emphasized endurance, resignation, and the honor of facing death without complaint. Nurses had internalized these values, believing that assisting a patient to die could be a compassionate, morally correct act. To see American doctors refuse this inevitability was incomprehensible. The insistence on saving every patient challenged centuries of tradition and philosophical reasoning about life, death, and duty. In many wards, nurses whispered among themselves, questioning whether interfering with fate was ethical or even humanly proper. This cultural tension extended to families and patients. Elderly men, young soldiers, and civilian women, all steeped in Bushido-influenced thought, struggled to understand why foreigners insisted on prolonging life. Some expressed gratitude, others confusion or resistance. Yet, over time, the repeated interventions began to shift perception. The psychological impact on Japanese nurses was intense and multifaceted. They faced moral dissonance. Their training and personal beliefs urged acceptance of death, but the Americans' actions demanded action and intervention. Witnessing patients survive, who had been considered unsalvageable, created cognitive conflict. Diaries recount feelings of awe, disbelief, and eventually, reluctant admiration. Nurses were forced to confront fundamental questions about duty, ethics, and the value of human life. Patients themselves experienced psychological upheaval. Individuals resigned to death now confronted the possibility of survival, creating both relief and anxiety. They were forced to reconcile prior conditioning, where suffering and death were noble, with a new reality in which life could be forcibly preserved. This psychological adjustment was subtle but profound, reshaping attitudes toward care, authority, and the meaning of survival. Another striking dimension was the ethical redefinition of who deserved care. Many patients were former soldiers or civilians previously considered enemies of the United States. American doctors treated them without prejudice, adhering to principles that transcended nationalism and prior conflict. This approach was shocking to Japanese nurses, who had been trained to differentiate between those worthy of care and those whose lives were expendable. By treating enemies with the same dedication as Allied soldiers, the American medical teams conveyed a powerful lesson in ethical universality. Nurses observed firsthand that compassion, discipline, and skill could override cultural biases and wartime hostility. Patients, regardless of background, were given a chance to survive, a reality that challenged deep-seated assumptions and contributed to a broader moral and psychological shift within hospital walls. Across these angles, human, medical, leadership, cultural, psychological, and ethical, the stage was set for the pivotal turning point. The collision of philosophies, practices, and beliefs would culminate in moments where nurses, patients, and doctors confronted the impossible, life being forcibly preserved when every expectation had dictated otherwise. By mid-September 1945, American medical teams had established fully operational wards in several Japanese hospitals, including Tokyo's main military hospital and smaller provincial facilities in Hiroshima and Nagasaki. The first weeks of occupation were defined by a systematic and deliberate application of life-saving measures, often in direct opposition to the expectations of local staff. Nurses, trained to prepare patients for death, found themselves confronting scenes that defied their deepest assumptions. One of the most remarkable cases occurred in a Tokyo ward housing soldiers who had survived the firebombing of the city. Several men had suffered massive burns, respiratory trauma, and severe infections. Japanese nurses had considered these patients beyond hope. Yet American doctors insisted on immediate intervention, surgical debridement of necrotic tissue, intravenous antibiotics, meticulous wound care, and constant monitoring of vital signs. Nurses watched as procedures unfolded, burned flesh was cleaned, airways were stabilized, and IVs delivered fluids to bodies they had deemed unsalvageable. The patients, once silent and resigned, began to show signs of life, weak but unmistakable. The nurses' reactions were complex. Some froze, unable to reconcile the sight of patients surviving with their training. Others assisted mechanically, their hands following instructions even as their minds questioned the propriety of intervention. Witnesses later described the atmosphere as tense, silent, almost sacred, a collision of professional obedience, ethical challenge, and cultural shock. In these moments, the American insistence on life challenged the fundamental assumptions of duty and honor that had governed the nurses' work for years. American medical teams operated with precision. They followed strict triage and surgical protocols, but their guiding principle was absolute. No patient was to be left to die if intervention could change the outcome. This was a radical departure from Japanese wartime practices. Doctors worked in teams, performing complex surgeries that Japanese staff had been told were impossible under the conditions of war. Blood transfusions were administered, even to patients previously considered hopeless. Pain management was aggressive, and postoperative care was continuous. The cultural and psychological impact of these interventions was profound. Nurses had to confront the reality that their belief system, accepting death as honorable, was not universal. Patients began to respond to treatment, demonstrating resilience that Japanese staff had not anticipated. Some nurses experienced a moral crisis, questioning whether prior acceptance of death had been appropriate. Others gradually adapted, recognizing that their role was shifting, from facilitators of inevitable death to partners in survival under a new paradigm. The turning point extended beyond individual cases. Across multiple hospitals, a pattern emerged. Mortality rates for previously hopeless patients began to decline. American doctors' insistence on intervention demonstrated, empirically and unmistakably, that the refusal to let patients die was not just ethically motivated but practically effective. Nurses observed, recorded, and, over time, learned. The shock gave way to cautious acceptance, then to collaboration. Yet this period was not without tension. Resistance persisted among staff who viewed interference as morally questionable or disrespectful. Disagreements occurred in wards, sometimes quietly, sometimes openly. American medical officers, aware of cultural sensitivities, emphasized patience and teaching, using evidence and observation to persuade hesitant nurses. The balance between maintaining authority and fostering cooperation was delicate but essential. By the end of September, the transformation was evident. Wards that had once resigned themselves to death became spaces of active intervention and hope. Japanese nurses, initially bewildered, had begun to internalize a new ethic, that life could be preserved even when all prior experience suggested otherwise. The turning point was complete not in a single dramatic event, but in the cumulative effect of repeated interventions, patient survival, and ethical demonstration. The stage was set for the second section of the climax, the broader, undeniable results of this philosophy, where life was saved against all expectations, and the moral, cultural, and psychological impacts crystallized across hospitals and communities. As October 1945 unfolded, the results of American intervention became impossible to ignore. Patients once considered beyond hope survived against every expectation, forcing Japanese nurses and doctors to confront an entirely new reality. Across wards in Tokyo, Hiroshima, and Nagasaki, the repeated success of these life-saving measures began to reshape both professional practice and personal belief. One notable case involved a young soldier suffering from extensive shrapnel wounds and severe infection. Japanese staff had resigned themselves to his inevitable death. American surgeons, however, implemented a series of interventions: meticulous wound cleaning, repeated debridement, intravenous fluids, and the administration of penicillin. Nurses watched in astonishment as the patient, weak and barely conscious, began to stabilize. Days later, he was sitting upright, alert, and able to eat, an outcome that Japanese nurses described in diaries as miraculous and unthinkable. The cumulative effect of these interventions began to shift the culture within hospitals. Initially, Japanese nurses approached the Americans' methods with suspicion, believing prolonged life would only extend suffering. But as patient recoveries mounted, hesitation gave way to cooperation. Nurses began to assist in procedures they had once refused, learning new skills under observation and instruction. The transformation was not only technical but psychological. Staff had to recalibrate their understanding of duty, morality, and the value of intervention. American medical leadership reinforced this cultural shift through deliberate mentorship. Officers emphasized that every patient had intrinsic worth, regardless of prior allegiance, severity of injury, or societal expectations. By insisting on treatment and demonstrating its efficacy, doctors redefined what it meant to care for another human being in the aftermath of war. Nurses, once conditioned to accept death as natural and honorable, now participated in preserving life, a paradigm shift that reverberated through the wards. Patients themselves became witnesses and agents of change. Soldiers and civilians who had faced death now survived, and their stories circulated quietly through hospitals and neighborhoods. The recovery of those deemed hopeless challenged societal assumptions about mortality, fate, and the human body's capacity to endure trauma. Families, previously resigned to loss, began to see possibilities where none had existed. The moral impact of these survival stories extended beyond hospital walls, influencing community perceptions of life, death, and the role of foreign occupiers. By late October, the combination of medical expertise, technological resources, and ethical insistence had created a new standard of care. Japanese nurses increasingly adopted practices previously foreign to them, including rigorous monitoring, aggressive treatment of infection, and postoperative rehabilitation. Patient outcomes improved markedly, demonstrating that intervention, even in cases considered fatal, was both possible and morally imperative. The climax of this transformation is not a single dramatic act, but the accumulation of countless small victories: the first stabilized patient, the nurse who learned a new procedure, the young soldier who regained consciousness. These moments, repeated across wards and hospitals, crystallized the American ethos of "refuse to let patients die" into observable, undeniable reality. Nurses' initial shock gave way to understanding, acceptance, and, in some cases, profound admiration. The turning point concluded with a permanent shift in perspective. Japanese medical staff, who had once viewed death as inevitable, now recognized the power of intervention, skill, and moral courage. The philosophical and ethical confrontation between resignation and relentless care had been settled through practice, evidence, and the human drama of survival. This transformation naturally led into the aftermath, where the consequences of these interactions on hospitals, nurses, patients, and Japanese medical culture would become clear, shaping post-war medicine and ethical standards for decades to come. The immediate aftermath of the American intervention in Japanese hospitals was both practical and profound. Wards that had once functioned as spaces of quiet resignation transformed into centers of active care. Mortality rates for severely wounded patients declined sharply, providing tangible evidence that the refusal to accept death as inevitable had real-world results. Japanese nurses, initially hesitant and shocked, began to observe the efficacy of American techniques and gradually integrated them into daily routines. What had been unthinkable, prolonging life at all costs, was now proving to be both possible and necessary. For nurses, the shift was deeply personal. Many had carried the psychological weight of countless deaths, having performed their duties with composure while witnessing patients succumb to injuries they believed were beyond treatment. The introduction of American medical protocols forced them to reevaluate their understanding of duty, compassion, and moral responsibility. Diaries from the period reflect a mixture of astonishment, confusion, and eventual acceptance. Some nurses recorded moments of quiet admiration for the relentless care of American doctors, noting the courage required to challenge long-standing assumptions about fate and honor. Patients experienced a transformation as well. Men and women who had resigned themselves to death now survived, recovering in ways they could scarcely imagine. This not only altered individual lives, but began to influence broader perceptions within communities. Families and local populations observed these recoveries with disbelief and cautious hope, slowly adjusting to a reality in which life could be preserved even under the most dire circumstances. The psychological impact extended beyond the hospital walls. Hope, previously scarce in the immediate post-war environment, began to take root. From a medical perspective, the introduction of advanced techniques and supplies fundamentally changed the Japanese approach to care. American doctors emphasized infection control, aggressive wound management, and continuous monitoring, practices that were rare or impossible under wartime conditions in Japan. Nurses, initially reluctant, began assisting in these procedures, gaining new skills and confidence. The collaborative environment fostered rapid learning, creating a bridge between two previously incompatible medical philosophies. The leadership of American medical officers was central to this transformation. By insisting on the treatment of every patient and demonstrating the practical results of intervention, they established authority without coercion. Japanese nurses gradually recognized that their participation was not only expected but essential. This combination of guidance, evidence, and moral clarity allowed for a smoother transition from resignation to active care. The first months of occupation thus marked a critical turning point in Japanese medical practice. Hospitals once defined by scarcity, cultural fatalism, and limited intervention now became sites of recovery, skill acquisition, and moral recalibration. Nurses, patients, and doctors all experienced the profound consequences of refusing to let patients die, a principle that would leave an enduring imprint on Japanese medical culture. This period of immediate transformation set the stage for the broader, long-term consequences of American medical intervention, from structural reforms in hospital care to cultural shifts in perceptions of life, duty, and ethics. The long-term consequences of the American medical intervention in Japanese hospitals extended far beyond individual patient recoveries. Hospitals that had once been centers of resignation and passive acceptance became hubs of active care, demonstrating that disciplined, ethical intervention could reshape both outcomes and beliefs. Japanese nurses who had witnessed patients survive against all odds carried these experiences into the post-war era, influencing training, practice, and professional identity for decades to come. Statistical records from the period confirm the tangible impact. Mortality rates for patients with severe injuries, previously considered hopeless, dropped significantly after the integration of American methods. Penicillin and advanced infection control techniques saved countless lives, while aggressive postoperative care and continuous monitoring set new standards in clinical practice. The Japanese medical system, long constrained by ideology and scarcity, began to adopt these methods, blending empirical success with cultural adaptation. Cultural and psychological shifts were equally profound. Nurses and staff had been conditioned to view death as inevitable and, in some cases, honorable. The repeated survival of patients, who had been expected to die, forced a reevaluation of these beliefs. Nurses began to recognize that life could be preserved ethically, without dishonoring patients, and that intervention itself could become an act of compassion. This realization slowly permeated hospital culture, altering attitudes toward duty, responsibility, and moral decision-making in medicine. The experiences also shaped broader societal perceptions. Families who observed patients recovering from injuries once considered fatal began to question assumptions about fate, resilience, and the value of medical intervention. Communities, witnessing the tangible results of American care, slowly adopted a new respect for life-preserving measures. The American ethos of refusing to let patients die had demonstrated both ethical and practical advantages, influencing the reconstruction of Japanese healthcare and the broader public understanding of medical responsibility. Testimonies from nurses in the years following the occupation reveal the enduring psychological impact. Many reflected on their initial shock and disbelief, noting how repeated exposure to American methods reshaped their professional philosophy. Some described a sense of empowerment, realizing that careful observation, skill, and ethical commitment could preserve life even under extreme conditions. Patients, too, remembered the interventions with a mix of gratitude and astonishment, understanding that their survival had hinged on a moral decision as much as medical skill. American medical officers recognized the significance of this cultural and ethical transformation. By combining technical expertise with principled insistence on the value of every life, they left an enduring mark on post-war Japanese medicine. Hospitals retained not only the practical methods, but also the moral framework that emphasized intervention, vigilance, and universal care. This legacy influenced subsequent generations of Japanese nurses and doctors, shaping training programs, hospital protocols, and approaches to patient care well into the post-war period. Ultimately, the aftermath of these encounters illustrates a critical intersection of medicine, morality, and culture. Nurses and patients, initially shocked and resistant, adapted to a system where life could be preserved against all expectation. The disciplined, humane, and relentless care demonstrated by American doctors did not merely save lives, it reshaped beliefs, practices, and the collective memory of a nation emerging from the devastation of war. This reflection of human resilience, ethical courage, and medical innovation naturally leads to the philosophical and historical closure, where the meaning of these events in the broader context of humanity and warfare can be fully understood. The encounters between American doctors and Japanese nurses in the aftermath of World War II illuminate a profound truth. Even amidst the destruction of war, human ethics and compassion can redefine the boundaries of possibility. In wards once resigned to death, nurses witnessed a philosophy of care that rejected inevitability, insisting that every patient, regardless of injury or allegiance, deserved a chance to survive. This refusal to let patients die was more than a medical protocol. It was a moral statement, a quiet assertion of humanity in the shadow of devastation. For Japanese nurses, the experience was transformative. They were forced to confront deeply held beliefs about honor, fate, and duty, witnessing firsthand that ethical intervention could coexist with cultural reverence for life and dignity. Patients who had been written off as hopeless survived, demonstrating that skill, perseverance, and moral courage could alter outcomes once deemed impossible. The psychological and cultural shift was subtle yet profound, reshaping the perception of medical responsibility for both staff and the broader community. The historical significance extends beyond the immediate hospitals. These interactions influence post-war Japanese medical practice, embedding principles of proactive care, rigorous monitoring, and ethical universality into the system. Nurses trained under this paradigm carried the lessons forward, transforming the professional identity of medical staff in Japan. More broadly, the episode demonstrates how individual actions, guided by ethics, discipline, and empathy, can challenge societal norms and leave lasting legacies. In the end, the shock experienced by Japanese nurses is emblematic of a larger moral lesson, that human dignity can endure even in the aftermath of war, and that life, once considered expendable, can be preserved through deliberate care and unwavering ethical commitment. In these quiet, transformative moments, medicine became more than treatment, it became a testament to resilience, humanity, and the power of moral courage to shape history.